In this video, we will discuss the radiological perspectives of SARS-CoV-2 infection. Chest radiographs are one of the most common investigations performed in SARS-CoV-2 infection. Any patient with severe acute respiratory illness will need a chest X-ray. Chest X-ray can have normal findings or can have classical findings as multiple bilateral areas of ground glass opacity which are predominantly peripheral and have a lower lobe predominance. Certain findings like pneumothorax, pleural effusion, pulmonary edema and pneumatocyst formation are uncommon in COVID infection. In many cases, the findings can be indeterminate and will need further investigations. Computer tomography is another common investigation used in SARS-CoV-2 infection. However, it is not a first-line investigation in all patients. It is useful in suspected cases when the RT-PCR is negative or delayed and in those with equivocal chest X-ray pattern. It is also useful in those undergoing emergency surgeries or interventions and procedures which are high aerosol generating. CT chest in proven cases is indicated only in severe acute respiratory infection. A lower threshold is needed in those with high risk factors. If there is a disparity in clinical finding or unexplained deterioration, or when one suspects complication as infection or air leak, CT is preferred. In those cases where pulmonary embolism is strongly suspected, a CT pulmonary angiography may be done. Ground glass opacities reflect air space involvement. Crazy paving pattern indicates air space and septal involvement, secondary to interstitial vasculitis and pulmonary venous involvement. Both ground glass opacity and crazy paving pattern progress into dense consolidation. In the early stages of disease, from 0 to 4 days, ground glass opacities, partial crazy paving are the most common findings. In the second stage, which is the progressive stage between 5 to 8 days, there is extension of ground glass opacity and increased crazy paving pattern. During the second week of illness, dense consolidations are known to occur. During the adsorption stage, there is gradual resolution of these findings. Radiological resolution takes longer time than clinical resolution. Halo sign indicates central consolidation with surrounding ground glassing opacity. Reverse halo sign or atoll sign indicates central ground glassing with surrounding consolidation. These signs are typically seen in organizing pneumonia, however can sometimes be seen in COVID pneumonia as well. The Dutch Radiological Society came with a categorical assessment scheme for reporting chest CT in COVID suspects. CORAD scheme denotes the level of suspicion for pulmonary involvement. It does not correlate with clinical severity. CORADS 1 has normal CT findings and there is no suspicion of COVID-19. In CORADS 2, the abnormalities are consistent with infections other than COVID-19. CORADS 3 has indeterminate findings. CORADS 4 has abnormalities which are suspicious for COVID-19. And CORADS 5 have abnormalities which are typical of COVID-19. CORADS 6 is where there is PCR positivity irrespective of CT findings. The CT severity score or index is based on severity of individual lobe involvement. Each lobe involvement is given a score of 1 to high depending on the severity of involvement. A score of less than 8 is considered to be mild, 9 to 15 as moderate and more than 15 as severe. In some places, a score of 9 to 17 is taken as moderate and more than 17 as severe. Since the CT severity score takes into account of only the severity of lobe involvement and does not indicate the nature of involvement, this does not correlate with clinical severity. There are several other scoring systems that are commonly used. A 40-point score is another score where The 18 segments of each lung is divided into 20 regions, and each region is scored from 0 to 2 based on the degree of parenchymal opacification. A score of less than 19.5 could rule out severe disease. This has a good negative predictive value of about 96%. The disparity between CT score and clinical condition may be related to patient factors such as age and comorbidity, the nature of CT lesion, a varying degree of pulmonary vascular involvement ranging from large to small vessel. Finally, CT scan is also very important for assessing complications such as secondary infection, pulmonary embolism, and hemopsis, especially in a setting of TB co-infection or underlying malignancy. It is also useful in long COVID patients who have classical peripheral pruning of vessels, suggestive of arteriopathy, and for lung fibrosis. We would like to acknowledge our radiology colleague Dr. Santhakumar for his valuable inputs in this video. If you like these videos, please like and subscribe us and follow us for more updates.